Um, so in the interest of time, I'll move on to case 4 now. So in case 4, you receive another call from your state's Department of Health. There's another newborn. This one's screened positive for Pompe disease. And so you do the same thing. You refer the patient to the nearest neuromuscular clinic and add them on for an urgent visit. And what do you see on physical exam? You can see a normal exam. This patient may look totally normal in your clinic, this infant, but you might see some of the signs of Pompe disease, including macroglossia, enlarged tongue, hepatosplenomegaly, hypotonia, and muscle weakness. And this is a situation where doing a good physical exam is really important. So there are 2 general forms of Pompe disease recognized in infancy: infantile onset and late onset. And you can see that there's a lot of manifestations of the infantile onset. It's usually not subtle. And in most cases, you can easily distinguish between the 2, although, of course, there are some ambiguous cases that give you a little bit of trouble in terms of classification. So there are lots of questions that come up in these newborn screen patients. If the infant has infantile onset Pompe disease, you want to move ahead with enzyme replacement therapy as soon as possible. If the patient has late onset Pompe disease and looks pretty good, then it's a little bit trickier, and the enzyme replacement therapy does require frequent intravenous infusions. So you do want to think about whether you want to treat immediately or not, and this entails a significant discussion with the family. And this is just a paper that we recently published where we determined how one might predict infantile onset versus late onset, depending on the type of mutation you have in the gene. So this is something that becomes tricky, especially if it's not an infantile onset case, in terms of what you'll do. And this involves careful discussions with the family, with the subspecialists, and everybody coming to a consensus, ideally, on what the best plan is for the child. And case 5, I'll just discuss briefly, is an adolescent male who presents at 16 years. He presents with this unusual presentation of full body paralysis that can last for hours. This started at 3 years, and it's been getting worse. And there are numerous triggers that he's identified, including carbohydrate-rich foods. He was diagnosed with hypokalemic periodic paralysis. This is a dominant disorder, and there are other family members affected. The first-line therapy is some oral potassium supplementation. There are other the medications that involve alterations in ion shifts that he's tried, and we tried some of the traditional ones. None are specifically approved by the FDA for this diagnosis among these older ones. So we moved on to dichlorphenamide, which was approved in 2015 after he failed some of the older therapies. And this was added to his current regimen, and he had a really good response. And so this is something that we found to be really heartening, and it made a difference in his quality of life. So let's move on to the summary. Newborn screening is really helpful for diagnosing several pediatric neuromuscular disorders, and I envision newborn screening will only expand in the future. The panels still differ from state to state. It will be nice in the future if we were to converge upon more common panels in the future, but that's still something that will take some time. It is important to recognize symptoms and signs of neuromuscular disorders in childhood. Newborn screening will definitely not pick up everything. There are some really thrilling new developments in the therapeutic realm. Several therapies have been improved over the past decade, which really are transforming care for these patients. It is important to weigh risks and benefits of therapies when counseling families about their options. So I'd like to end and want to thank colleagues at our Muscular Dystrophy Center and my laboratory, whose work I presented in part, and some of the funders who've helped us. And I'll be happy to take questions for this next segment. Thank you.
So Peter, thank you so much for opening a window to the newest therapies used to help children, youth, and adults with neuromuscular disabilities. I was actually trying to sort of understand more about the gene therapy aspect and wanted to just review this to make sure I had this right. Would that be okay?
Of course.
Okay. So people with Duchenne muscular dystrophy have a progressive muscle weakness, and that's because of a muscle protein that doesn't work. And that's because the gene that's responsible for its production is dysfunctional. And I guess that's what we call the dysfunctional dystrophin gene. And in gene therapy, you actually modify a dystrophin gene that is functional. You package it into a virus, and the virus gets injected, and the injected virus infects the human cell, but in a good way. And the human cells, by that I mean the muscles, and places the gene in a safe part of the human cell. So the new gene doesn't become part of the human DNA, but it still remains on the side.